and we will work through. And really, what I want to draw your attention to is that we are welcoming everybody here, as we always do. And the article that we're going to really spend some time digging in and talking about today is entitled "The Pharmacological Treatments for Fatigue Associated with Palliative Care." And it is actually an executive summary of a Cochrane collaboration and systematic review. So I'll be able to walk through and talk to you a little bit about that as we go through and really talk what it is. But I can tell you through my time, for those of you who know, I've worked with oncology and palliative care patients for quite a few years, and I struggle with the issue of fatigue and feeling kind of helpless in how to actually help clients overcome that. So we did a little bit of digging and decided to work through. So why did I choose this paper? Well, it is a symptom that patients often report. Like I said, I have had many patients tell me that they've had that tiredness, that fatigue, and I just didn't have a good answer. There wasn't a clear treatment path. If you go on to the Cancer Care Ontario algorithms, you'll see that exercise is still listed as one of the great things, but a lot of my patients didn't resonate with them, didn't feel like a good option. So that wasn't always the best option there. This is a different type of literature, and one of them that we wanted to talk about, the Cochrane reviews, and to really get into that a little bit. And then I'd like to point out that this is open access. So one of the things we really strive for in our journal club is to pick articles that we are allowed to freely use because they're open to everybody and that has that open access. But the honest answer is what brought me to this topic is the article below. So you can see it has a very long list of people. It's very new. It was just released in 2020, and it was a great study that caught my eye that talked about the methylphenidate, so the Ritalin, as needed for fatigue in patients with advanced cancer. It was a prospective, double-blind, placebo-controlled study, and I was so interested, and I thought I'd found a winner. I even emailed Kate and told her, I can't believe this article I found, it's great. We picked this topic, and then I found out it would cost me $36.95 or some amount of money, and I couldn't share it with all of you because it was not an open access article. So I did some looking backwards and found out that the article we're actually going to talk about was referenced in this new study. So I do have some of the information from that study, and we'll talk about it a little bit later in the presentation, but this is an example of me going backwards. So what I really wanted was this article, but it wasn't open access. So I moved backwards to see what else I could get that would be able to support our needs today. So just starting out and thinking about it from the beginning. So what about fatigue? So I did what any good palliative care nurse would do when I was looking for what is the good definition of fatigue, is I went to my trusty Pallium and I went back to the index, and lo and behold, fatigue is not even listed in the index of Pallium. It's not there. It doesn't have tiredness. It doesn't have those. And I thought, interesting. But so I went to look at a few other things. So Up to Date is one of the other resources that I do use fairly frequently. And it talks about it being the most common symptom in palliative care patients with advanced disease, the most common that it is. It talks about describing it as that subjective state. So it's how does a patient describe it? That they feel tired. They can't have the ability to do the physical or even mental work that they want to. For the purpose of our article that we're going to talk about today, they use the definition as fatigue is a subjective feeling of tiredness, weakness, or lack of energy. That is a definition that comes out of European descent, but that was the description that they had. And I think it's important for us to remember that. The other thing that they really mentioned when I was doing a lot of reading about fatigue on the different websites and how you look at it is it's not a clearly defined thing, which does hurt the research. And you'll see that as we go forward. But it's very important to differentiate this from other symptoms. And as we all know, working with palliative care patients, often the symptoms overlap and they're intermingled. So hard to sometimes have a client put their finger on that they're fatigued or they're tired, or is it related to them having pain? Or is it related to something else that is happening, but I don't think there's anybody that will argue that it has a huge impact on the quality of life of patients. And that is really truly why I wanted to look and see what else is out there that we could be offering that we might be overlooking, or maybe that some more information is needed about. So we always talk about this and see where are we in our hierarchy of evidence and everything that we want to look at. Last month, we had a cohort study, which is down a little bit further in the pyramid. And this month, we're jumping back up to the top. And this is some pretty strong evidence and a pretty good review that we're looking at. And we're going to delve into that a little bit more and talk about, well, what is a Cochrane review? So this is our evidence that we want to review today. And really, it's important for us to look at this because I'm not sure how many people are actually familiar with Cochrane reviews. So some organizations may have a subscription to the Cochrane Library. I'd encourage you to look and see if you do. I don't have one anymore, but I have in the past, and I really enjoyed it. And it was something that I would use. And a lot of times, what they do is they have this ability, they have a very strict set of standards that they look at, and they publish them through this Cochrane database of systematic reviews. So they have to meet their quality criteria, and it's almost in a way like a brand name. So you know that if something is a Cochrane review, that it's met the strict criteria that they've put forward, and it's been put through all of those things. One thing I noticed when I was reading this Cochrane review is they're very quick to point out the biases or the limitations. And that was really helpful for me. Before I got too invested in the information, they would make sure to tell me what the downsides could be. So you certainly can look it up. They have a handbook that goes through all those specific criteria and lists out what all of those different studies and papers need to have as part of them in order to be included in part of this. So they do have different types of reviews. So depending on the information you're looking for, you may be able to get some. So I would encourage you to look and see if this is something that you have access to. So what truly was the aim of this paper was they wanted to look at the efficacy of the pharmacological treatments for fatigue. So looking right at those treatments in palliative care, and they focused on a few different subtypes, but there was a focus on patients with that advanced state of disease. And they did include patients with cancer as well as other chronic diseases. When you start to dig into the paper, you can see that there was some very specific diseases. Cancer was a big part of it, multiple sclerosis. They did a fairly deep dive in regards to it as well. So what can I learn from this article? Well, there was some few things that came out of it that I wanted to highlight and wanted to talk about as we went through. So overall, when they went through and did the review, they looked and got it down to 45 studies that met the criteria that they wanted to use to bring this through. They looked at 18 different drugs within those 45 studies. There was 9 different diseases and 4,696 patients in total. However, they do very much indicate right up front in the article, if you read it, that only 2 of the studies had a population or a patient group that actually would be high enough to really give you some strong evidence that would come out of it. So only 2 of the studies had an enrolled population that finished the study of over 200 patients. And that is something that is important to take out of it. It's also very interesting to me because, as you heard me say earlier, fatigue is one of the most commonly reported symptoms, and yet there isn't strong evidence supporting the research into how we can help treat it. So there was 2 drugs that really kind of came forward, is ones that kind of led the way in that had the most evidence about them. And one of them was methylphenidate, so Ritalin. And interesting, I have, a little bit of experience with that, but not a whole lot. I think you all are probably knowing, as in your backgrounds too, expected dexamethasone to be on that list. And it wasn't one that there was a lot of information about, but that one was. The other drug, the modafinil, It's been a long day. It was in related to the multiple sclerosis. That was the drug that they looked at in regards to that disease. And there was some promising evidence in regards to that. But again, not enough to firmly say that we should absolutely go forward, but they would definitely both be on the promising level of what we had. There was some weak, or what they would call inconclusive, evidence about the drugs that I've listed there. You can see that they listed the mondofilin again under MS because the evidence wasn't quite as strong as it could have been. And then they also listed that they felt some further trials for certain drugs would be warranted. And that is where dexamethasone was listed, is that they felt that there was evidence there that would lead you to suggesting that there should be some more information. There was another drug that they did study for a while in regards to multiple sclerosis and was showing some benefit. However, it's been pulled by the FDA in the States due to side effects. So I didn't include it in this review as because of that reason. So when I look through everything and come out on the other side, what did they really come out with as a conclusion? Well, they acknowledge that this is a very complex issue. I don't think that's anything new that I'm telling to you. They acknowledge that there isn't a firm understanding of what is fatigue. And because of that, that was hard for them to get through. It was hard to help recruit people and carry through, because you're asking people who are tired to support you and to fill out paperwork and to come back over and over again and do these kinds of things. They did also have that agreement that there was a huge impact on the quality of life, and that some of the studies that are out there looking at non-pharmacological supports should maybe get another look, and that we really should be thinking about what else can we do and how can we find a way to help this. They also, as I said, mentioned the potential biases that were out there, that that they were small sample sizes, that at times there wasn't a clear indication of the exact process, or the sample size was so small that they couldn't come to draw that strong conclusion. But they did strongly say that they feel that there's a potential role for pharmacological supports. And this is where I just want to mention that other article that draw me to it. So even though I wasn't able to share the article with everybody as a whole, what I was able to do was to gather the information as to why did they actually think that it was possible. So from the summary, and then was able to to glean from that. And what they did in a way is they measured the level of fatigue and tiredness, and they used the ESAS. So that'll come up again later. And they used other tools as well, and they got patients to rate it. And then what they did was they gave patients the Ritalin or methylphenidate, and then they also gave them placebo. And they said, do this, fill out your level of tiredness, take a met pill, and then fill out another form 2 hours after and 5 hours after. And what they found was when the patients took the actual Ritalin, they had decreasing levels of tiredness at 2 and 5 hours, more so than when they took the placebo. There was still a decrease, that effect that you can get from people, but there was some benefit there. However, again, they struggled to keep people enrolled in the study, and they weren't firm on how often the patients could take it. So patients could repeat that dose within that 5-hour time frame. So they, before the other medication would have worn off. So there was a bit of overlap where if you were going ahead to do another study, they would have to have a bit more stringent control on some of those things. Some of the other things that made me, when I went looking, was looking at some of the supports and other reasons that are out there. And there's not a lot of strong support. As I said, it's not even listed in the Palliative as a symptom for which there are a list of pharmacological supports that are out there. So this at least gave us a bit of an idea of some possible starting doses, some possible medications to look a little bit further into. And I think that that's a really helpful way to kind of wrap up this part of our conversation, description of the study, and then moving on to our discussion. So I'm just going to pause the recording. So just want to take a few minutes and summarize our discussion that we had in regards to some of the other things in regards to fatigue. So we looked at some of the non-pharmacological strategies. So what are we able to offer out to people when we have the concern brought forward about fatigue? And we talked about energy conservation. We talked about thinking about what is important for you and re-looking at your day and how can we help support you. There was an interesting idea brought forward too, where when we are sometimes offering more help to clients so that we can help them conserve energy for another time, we are sometimes taking away a bit of that independence, which was an interesting concept and something that I hadn't thought about for sure. The other thing that comes up when we talk about non-pharmacological strategies is the idea of exercise, as that is a recommendation that it goes out through CCO, and it is something that we talk about, but it is hard for a lot of our clients to really get behind exercising towards the end of life. And then we did spend some time talking about our experiences. What clients had we looked after? What was the impact of that fatigue on their quality of life? And what came forward out of our discussion was a real understanding that we often have overlying symptoms. So clients may be suffering from depression and fatigue. They may be suffering from pain and fatigue. And there are other clients that are used to it. Do we not hear this complaint as much because people expect to have it? Or they've had fatigue for so long that they don't know how to express it. We also spent some time talking about the differences in how it is such a subjective symptom that we are talking about, that people don't really know how to describe it and give it that good description. Just as we struggle with as healthcare providers, so do the patients. So how do we assess fatigue? If we do at all, do we look at how the clients report it? Do we look at the ESAS? When we have that reported, I was thinking back about some of my experiences. How often are you contacted by somebody with a concern about a high ESAS for fatigue? We also talked about how drowsiness is there, and that can cause some confusion as well. We will review that OPQRST in just a moment, and also bringing in the idea of the CCO algorithm. Within the CCO algorithm, it talks about how to work through that OPQRST UB and talks about some good questions to ask. And we've always supported using those that can be accessed through the Cancer Care Ontario website. In the article that we spoke of, they refer to several of the studies that use this functional assessment of chronic illness therapy fatigue scale. And we talked about this, but we really spent a lot of time diving into, do we need another tool or another way to assess people, or should we maximize the tools that we already have and use them to the most benefit? And, there was some feelings among the group that we really could do our best to help maximize. So that's where this Fraser's Health Symptom Assessment tool comes into play, and where we can look, and again, supported by some of those questions on the CCO algorithm, we can look and really delve into that issue about fatigue, asking some of those questions, talking about when it started, what makes it better and worse, giving it a rating, what have they tried for it, but also really importantly, understanding the impact on the client and what it truly means to them, and how much of this is impacting their quality of life, and really taking the time to think about those bottom two values. So then we spent some time talking about, well, what pharmacological treatments could we or should we try? So based on the study that we had read, there were some suggestions of medications that we could try. And looking at the methylphenidate and looking at some of those studies and what were the outcomes that they saw. We also talked about the idea of dexamethasone and acknowledging that both of those medications, you have to talk about weighing the risks and the benefits. And that is an important part of the discussion about whether you should try that. Should we be putting it forward for clients to have that full understanding of the risks and the benefits, and bringing in other team members that may be experts, talking about to our other palliative care groups, to the pharmacists in our area, looking what's out there and what is the evidence in their opinion and what other experience have they had with using these medications. So those were the top two drugs that we did speak about being able to, but both understanding that there are significant risks attached with both of them. And you do need to spend some time looking at those risks and benefits. So then we always like to add about what could be the barriers and how can we address them. So some of the barriers that we talked about is that sometimes clients get to the point where they're just thinking they don't want another medication to take, and they would, just feel that they have too many on board. That is something we would have to address. The other thing is that there may not be a lot of knowledge about what we can try and what we should try. So if we are talking about maybe the person who you're going to be sending a note to, whether it be a physician or a nurse practitioner, whoever the prescriber is, may not have experience prescribing these medications for patients for fatigue. So it's about having that wholesome conversation and looking at the evidence. In palliative care, we often talk about going back to Pallium, and there is no section within Pallium that can really explain and you can refer to go through what medications should you prescribe. So you have to be creative. And I think what this talked about when we talked about the barriers and how we address them is that we have to be open to that conversation. When a client comes to us and says that they have fatigue, there was a discussion about how a lot of us felt like we didn't have a good answer about what could we try and what could we do. And what we were hoping to be able to do by looking at this article was to be able to glean some insight into ways that we could address it, meaning things that we could look at as moving forward. So as we always do when we have our journal club, we always like to finish with a quote. And our quote of the day today was, "She stood in the storm, and when the wind did not blow her way, she adjusted her sails." And we feel that that reflects how we are working in healthcare. We are all working to do our best to help care for clients to do there. When we don't have the answer, which we don't, on how the best way is to treat fatigue, then we need to adjust our sails. So by having this conversation here in our journal club tonight, we're hoping that we are doing a bit of that and increasing our knowledge and interest in finding creative ways to be able to treat fatigue in our patients. So we look forward, hope you enjoy our posting and see some of our other sessions that are available on the Hope Palliative Care Nursing Education Forum on YouTube. And our next in-person session will be February the 23rd from 7 to 9 p.m. Take care.